In podcast episode number 67, I had an insightful conversation with Jente Wagemans about ankle sprains and chronic instability. Jente is a physiotherapist and researcher at the University of Antwerp, currently pursuing his PhD in collaboration with Ulster University and Bern University of Applied Sciences. And throughout his PhD, he has published several papers on ankle sprains and chronic ankle instability. To kick things off, Jente clarified that the correct term is currently lateral ligament injury, which involves inversion, internal rotation and supination. This is distinct from syndesmosis injuries, which occur in dorsiflexion with a rotational component of the talus into the mortise in external rotation. He also highlighted that chronic ankle instability remains a mystery, largely due to the lack of prospective data, although recurrent ankle sprains seem to be central to this issue. We then delved into the incidence and prevalence of these injuries. Jente shared that ankle sprains are the most prevalent lower limb injuries in college athletes, the NBA, NFL and volleyball, and the second most common in soccer, with a prevalence of 40% for chronic ankle instability. Next, we examined epidemiological data, which shows that women are twice as likely to suffer from an ankle sprain compared to men, with the highest incidence in children and adolescents. We also touched on modifiable risk factors such as high body mass index, asymmetry in eccentric strength in the ankle, decreased hip extension range of motion, and reduced postural balance. Ideal strength values for ankle dorsiflexion are 0.4 times the body weight and 1.7 times body weight for the soleus muscle in plantar flexion and 2 to 3 times body weight for the gastrocnemius. Furthermore, we discussed risk factors for developing chronic ankle instability, including decreased dorsiflexion range of motion and posterior glide kinematics of the talus. Jente also mentioned that poor postural balance, inability to perform single drop landings or vertical jumps, and longer stabilization time after landing are significant risk factors. A potential factor mentioned was delayed onset in peroneal co-contraction, identified as a risk factor in a single study. Jente suggested rehab options such as pre-stretching the peroneus with an elastic band into inversion during a landing task. We also covered possible red flags after ankle sprains, such as sinus tarsi syndrome, which can cause neurological symptoms due to swelling, compressing structures in the foot. For immediate post-injury care, the acronym PEACE and LOVE is recommended. It stands for Protect, Elevate, Avoid Anti-Inflammatories, Compress and Educate. LOVE, on the other hand, stands for Optimal Loading, Optimism, Vascularization and Exercise Therapy. We talked about orthopedic testing for ankle sprains. Jente's group is comparing orthopedic tests to MRI to determine the accuracy in diagnosing ligament injuries. He emphasized adapting rehab strategies based on the affected ligaments. For assessments, Jente tests range of motion, strength and balance, aligning patients' needs with his evaluations. For return to sports, he uses various hop tests and considers the patient's readiness to resume activity. In terms of management, Jente aims to reduce swelling and pain in the acute phase and promote tissue healing in the subacute phase. An exercise he recommends for all of his patients is cycling on an ergometer to improve vascularization and dorsiflexion ROM if there's a deficit. His rehab focuses on the identified impairments and includes neurocognitive tasks early on. For return to play, Jente looks at sport-specific requirements and progressively challenges athletes with more complex tasks. He also incorporates balance exercises that account for proximal disturbances, like those caused by shoulder pushes, not just balance board exercises. Lastly, we discussed taping and bracing. Semi-rigid bracing can limit ankle inversion without loosening, unlike tape. However, Jente stresses that bracing is supplementary and strengthening exercises are crucial. His meta-analysis shows that exercise-based rehab significantly reduces the risk of recurrent ankle sprains. In conclusion, the average time for return to sport is 10 to 14 days. But Jente noted that proper load tolerance is typically achieved around 70 days. Successful return to sport includes negative provocation tests, recovery of impairments, and the ability to perform neurocognitive tasks. Alright, that was a brief summary of podcast episode 67 on ankle sprains and chronic ankle instability with Jente Wagemans. I hope this piqued your interest to listen to the whole episode. For more resources, download our Physiotutors app for access to the transcript and infographics, and also to listen to the podcast in other languages. And as always, thanks for watching, and I'll see you in another video.